Now, this is the first case scenario that we have in Osce. A 57-year-old man has an out-of-hospital cardiac arrest. The return of spontaneous circulation occurs and he is being ventilated with a bag and mask. An arterial blood gas is performed on 15 liters of oxygen, and these are the results. What is your interpretation of the ABG?
The metabolic acidosis.
Metabolic acidosis. Okay. Only metabolic acidosis? Because the PaCO2, PO2 values are all given in kilopascals, I think you are finding it little difficult. How much is 1 millimeters of mercury equals 1 kilopascal?
7.56.
7.5 mm. So 1 kilopascal is equal to 7.5 millimeters of mercury. So PaCO2 multiplied 9 multiplied by 7.5, is it normal? PaCO2.
Oh, sir. High respiratory.
It is almost like 67 or something. Okay. So this is a respiratory component also. So yes, bicarb is low, pH is low, and PO2, is it corresponding to the level of FiO2?
No, sir. Okay.
That is also low. Okay. And base excess is low. And what about glucose?
Low.
Low.
Into 140 normally.
How will you convert millimole into milligrams? Glucose. How many milligrams are there in 1 millimole of glucose?
14.
You have to multiply by 18. Okay? So Western countries use only millimole, not milligrams like what we do. So 18 into 7, how much is that?
126.
Okay. What about lactate? Is it normal?
No, sir, increased. Sir.
Lactate is also high. Okay. So arterial oxygen level is lower than expected for the FiO2 being delivered. PaCO2 is also significantly elevated, indicating poor ventilation. And because pH is also low, there is a mixed respiratory and metabolic acidosis. Lactate is significantly reduced, contributing to the metabolic acidosis. Glucose mildly elevated, which may be stress response. And severe hyperkalemia. You can see potassium is 7.9 millimoles. And base excess consistent with metabolic acidosis. So what is the diagnosis and management? Diagnosis is, of course, combined metabolic and respiratory acidosis. How do you manage this case?
Fluid administration.
Identify and treat the potential underlying causes. That is 4, because it's a out of hospital cardiac arrest revival. So what are the causes of cardiac arrest? 4H and 4Ts. What are the 4Hs?
Hypoxia, hypothermia,
hypovolemia, and
cardiac tamponade, cardiac thrombosis, pulmonary thrombosis, and toxins.
So you must identify and treat that. Then patient has severe hyperkalemia, which requires immediate treatment. It can be done by IV calcium to stabilize the myocardium, followed by insulin dextrose infusion. And significant hypoxemia, FiO2 requires a definitive airway and optimized oxygen ventilation. Removal of the PaCO2 also to be taken care of. So these are all the management that you have to take. Okay. Now this drug is likely to come into market soon.
Yes, sir.
What is remimazolam?
It is a mixture of remifentanil with
Remifentanil and midazolam.
Midazolam, very good. So why they have combined these two drugs?
Shorter acting.
Both are short acting. So it is a intravenous sedative agent, combines the pharmacodynamics of midazolam and pharmacokinetic properties of remifentanil. Okay, that is what they have done to do that. What are the clinical uses of this drug?
can be
Sedation,
approved only for sedation,
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 scoping.
general anesthesia and ICU management. ICU sedation.
Procedural sedation you can use, then
ICU sedation we can use and
ICU
general
sedation you can
anesthesia.
use, very good.
For
Then
general anesthesia induction, sir.
For
induction
GA,
of general
induction
anesthesia.
and
Okay, so you can use it for procedural sedation
Minor
like
procedure.
endoscopic, diagnostic, or minor surgical procedure. You can use it as an induction and maintenance of anesthesia as a general anesthetic. You can use it for intensive care sedation. Very good. What are the different salts of remimazolam available?
Zolam chloride.
Hydrochloride.
Chloride. You have to start a manufacturing company to produce that. There is no chloride salt available. What is the salt of atracurium? It is commonly used.
Bacillate, sir.
Bacillate. So it is available as bacillate or tosylate. Okay. What is the chemical structure and mechanism of action of remimazolam? Under what category of drug it comes? Benzodiazepine or
Benzodiazepine.
opioid?
Benzodiazepine.
Comes under
Benzodiazepine.
benzodiazepine. Okay. So it has a
So GABA
carboxylic
GABA
ester
receptor.
group present in remifentanil, which is integrated into benzodiazepine 4. Okay. That is how the so it enhances the what is the mechanism of action?
GABA A chloride.
It acts again just like a GABA aminoreceptor type A inhibitory receptor with increased frequency, opening the ligand-gated chloride ion channels. So what will happen if the chloride channels are open?
Polarization.
Hyperpolarization.
Hyperpolarization. We saw in the earlier class, Nernst equation, I told you, if the intracellular negativity increases, it is called hyperpolarization. That is achieved by ingress of chloride ions into the cell. How is this drug metabolized?
Esterases. Non-specific esterases.
See, we have a carbolic acid ester. This is the clue that you have to.
Hydrolysis.
So you have to have an esterase, carbolic esterase. Any ester enzyme that will break down that carbolic ester or any ester is the esterases. Okay.
Yes, sir.
So hydrolyzed into inactive metabolite, which is called CNS7054 by carboxyl esterase 1 located in the liver. So it is metabolized in the liver. What are the adverse effects of this drug?
Respiratory depression.
Anaphylaxis,
Anaphylaxis and taste
delayed
disturbances.
emergence and resedation after removal, reversal even if clonazepam when there is a depression. These are considered. So just to show you some of the pictures of this drug which are already in the market in the we have not got it. So this is the presentation. It is presented as a powder or a
Powder.
stick. It is a powder. How do you reconstitute it?
We should not reconstitute with oral, sir, only or
Oral.
NS and distilled water. With the 12
Normally,
ml of.
do you reconstitute all powders with oral?
No, sir.
No, sir.
Then with what do you use to dissolve the powder?
Normal saline or a distilled water.
Water. So here, what do you have to use?
NS.
You have to use normal saline. How many ml of normal saline you have to use?
12 ml.
12 ml.
So confident. Presented as a 20 milligram powder, which is reconstituted with 8.2 ml of 0.9% sodium chloride solution. That is normal saline. Only 8.2 ml to be added.
Yes, sir.
And intravenous bolus dose followed by an infusion if necessary is the route of administration. And you can see the carton itself, it is given. You have to use 8.2 ml of 0.9% sodium chloride. What are the other components in this? Is there only the remimazole powder or other substances are there?
NaOH.
Soda bicarbonate.
Soda bicarb. Good guesswork. But if you put soda bicarb, what will be the pH?
Alkaline side.
Alkali. So you want it to be alkaline or acidic?
NaOH. Acidic.
Huh? So it has got other dextran, 10 milligram of dextran 40 is there, and there is lactose monohydrate, 6.7 milligrams of lactose monohydrate with hydrochloride or sodium hydrochloride, not bicarbonate. Okay, so that the pH is adjusted with hydrochloride or sodium hydroxide. Because these things will only give you a slightly acidic pH. Okay. So the other components apart from the remimazole powder are dextran 40 10 milligram and lactose monohydrate. Both are what is called bulking agents. And it is soluble slightly in acidic environments and can precipitate in lactated or acetate solutions such as ringer lactate or plasma lactate. So you should not use them. What is vagal tone? Its role in normal physiology. This is one of the articles which has come recently, the anesthesia tutorial of the week. So to keep you all abreast of the recent articles, suddenly they may ask you questions from that. And that is the reason why I have included this in the article.
Parasympathetic.
How do you define vagal tone? It's referred to the activity of vagus nerve, specifically its parasympathetic effect on the various organs. Okay. And its normal physiology, it measures the basal level of parasympathetic activity as a critical role in regulating the heart rate, digestion, various other autonomic functions, maintaining homeostasis, modulating the response to stress and rest. So we describe sympathetic activity as a flight and fright response. How do you describe the parasympathetic activity? Is there any equivalent description? Just like flight and fright response for sympathetic. Is there any description for parasympathetic?
Rest.
Rest and digest. Yes, very good. Answers are here. Rest and digest. Okay, that is how it is described. Enumerate the vagus nerve reflexes and their associated surgeries or procedures and clinical relevance. What are all the various reflexes that you can encounter during your anesthesia practice?
Oculocardiac
It
reflex.
involves the vagus
Trigeminal
nerve.
reflex.
Ocular respiratory reflex. Ocular gas.
Trigeminovagal, oculocardiac,
Oculoemetic. Oculoemetic, sir.
oculoemetic by vagus.
Baroreceptor.
Trigeminovagal and oculocardiac are two parts of the same nerve. Right, so this is the oculocardiac reflex, which is involved in the afferent pathway trigeminal. Clinical response is bradycardia, hypotension. They are encountered during strabismus surgery or orbital fracture repair or globe manipulation. Okay. Trigeminal-cardiac reflex again involves trigeminal. Again, the response is same, severe bradycardia, hypotension. It can happen during skull-based surgery or maxillofacial or neurosurgery. Then laryngeal reflex, superior laryngeal nerve, branch of vagus nerve, laryngospasm, apnea, bradycardia, can happen during light plane endotracheal intubation, bronchoscopy, or laryngeal surgeries. Then celiac reflex, where vagal afferent is from abdominal viscera, which will result in hypotension, bradycardia, visceral traction reflex during laparoscopic surgeries. We encounter this in laparoscopy or abdominal organ manipulation or pneumoperitoneum creation. Then basal gyrus reflex, which is a cardiac sensory fibers chemoreceptor, which will result in hypotension, bradycardia, vasodilation, and it can happen during spinal anesthesia. One of the important reasons of sudden cardiac arrest after spinal anesthesia is this basal gyrus reflex, especially in patients who have a high vagal tone. We have to be very, very careful. Interventional cardiology also can produce this. Then carotid sinus reflex, it is the afferent is the glossopharyngeal nerve from carotid receptor, which will also result in bradycardia and hypotension. Carotid endarterectomy or carotid sinus surgery, central line placement also sometimes can produce this. So these are all the situations where we encounter this. This one here,
Congenital
Convergent.
cataract.
bilateral congenital cataract. You can see both eyes are affected. So saying, what are the syndromes and metabolic disorders associated with congenital cataract?
Wilson syndrome, sir. Wilson syndrome, copper deficiency.
Congenital.
Down syndrome is very common. Turner syndrome and Lowy syndrome. Metabolic disorders, galactosemia and hypocalcemia. What are the acquired causes of cataract in children? This is
Sir.
congenital.
Torch
Infections.
Blunt or penetrating trauma, inflammation such as uveitis with juvenile chronic arthritis, tumors such as retinoblastoma also can cause cataract. Radiation for leukemia also can cause cataracts. Chronic steroid use also can result in cataract. What are the challenges in anesthesia for excision of cataract and IOL insertion?
Pediatric.
It's a pediatric
Oculocardiac
case.
reflex.
very good.
PONV.
Hyperthermia.
So oculocardiac, all that we already discussed. Challenges pediatric anesthesia, challenges of ophthalmic surgery. What are the important considerations in anesthetizing this child?
Anxiety. Separation anxiety.
Separation anxiety, if it is more than how many age, what is the age after which they develop this separation anxiety?
6.
6 up
6
4
months.
to 6 years.
Okay.
6 months to 6 years.
And another requirements are you require a completely akinetic eye, immobile eye. You must avoid rise in IOP, avoid hypercapnia, avoid post-term nausea, vomiting, and manage oculocardiac reflex if it happens. So these are all the intraoperative important. Now, a 26-year-old male with history of consuming some over-the-counter medication is brought to the emergency department because of previous history of altered mental status, vomiting, and vertigo. The physical examination is positive only for patient is likely somnolent or drowsy and tachypnea. Now they have taken a electrolyte estimation. Sodium is 143, chloride 100, bicarb is 16, and ABG, this is the value. pH is 7.5, PCO2 20, bicarbonate 15. What are these patients' acid-base disorders?
Metabolic alkalosis.
Alkalosis.
Metabolic,
Metabolic alkalosis.
With respiratory.
With respiratory condition.
what do you say metabolic alkalosis? Bicarb is only 15. Because the pH is on the alkalotic side, you say it is alkalosis.
Yes, sir.
Is it metabolic alkalosis or respiratory alkalosis?
Respiratory
Ah,
alkalosis.
washout of CO2 is there. I have given the normal values on the right side. Okay. So there is a respiratory alkalosis. pH is also higher on the alkalotic side. So this is not a very simple, straightforward ABG. You have to do some stepwise study. Calculate the anion gap first. Okay. What is the anion gap in this case? How do you calculate anion gap?
Sodium.
Unlisted.
Sodium plus potassium minus chloride plus bicarbonate.
Plus bicarbonate.
So here potassium is not given. So take the sodium alone. Chloride is 100, bicarb is 16. So 116 taken out from
27.
37. Very good. Anion gap is 27. 27, not 37.
27.
So it is too high by 16 points. Okay. Step 2. The serum bicarbonate is dropped in proportion to degree in which the anion binds to. So you have to find out the delta gap. Isn't it? So expected bicarb, what is the value? It should be 24 minus 16. This is the actual value. This is the range or normal range. This is the actual. So it should be only 8. But here it is 16. So the bicarbonate 16 is 8 points higher than the expected 8. So higher than expected bicarb in the patient with no past microbiology suggests a metabolic alkalosis also. Okay. Now step 3. Look at the arterial blood gas and see if the partial pressure of carbon dioxide is dropping in proportion to the drop in bicarbonate using the Winter's formula. What is Winter's formula?
Acute CO2 1.5
Expected PCO2 is equal to
1.5 into
so
bicarbonate.
his PCO2 should have been 32. That is 16 is the bicarb. 1.5 times of 16 is 24. Plus or minus 8 is so plus 8 is 32. So his actual PCO2 should be 32, but here it is only 20. So a too low PCO2 means there is a respiratory alkalosis going on here as well. Okay. So this patient's triple acid-base disorder is the high anion gap metabolic oxidation from step 1, metabolic alkalosis from step 2, and respiratory alkalosis from step 3. So this history alone suggests likely toxic because he said over-the-counter medication he has taken. There's a possibility which causes high anion gap is paracetamol. So that can acetyl salicylic acid, so that causes a high anion gap acidosis. And because he has been vomiting, that produces metabolic alkalosis also. And his tachypnea fits in with the respiratory alkalosis. So it may be a case of salicylate poisoning because of these 3 things that are happening. So this is a triple disorder. This is not a simple, straightforward, single disorder ABG. What is this?
Recruitment.
Recruitment maneuver, very good. The staircase recruitment maneuver. Called this, that's why it's called Tuxian staircase recruitment. What is lung recruitment maneuver?
To open
To
the
open up
collapsed
the
alveoli.
Open up
collapsed
the
alveoli.
collapsed airways. Very good. It's a transient sustained increase in transpulmonary pressure designed to open up collapsed airless alveoli. What are the indications for doing it? Which conditions you will get this?
ARDS, sir, acute
Atelectasis.
ARDS
ARDS part of open lung approach in mechanical ventilation. What are the advantages and disadvantages of this recruitment maneuver? What is the advantage? Will it improve oxygenation or decrease oxygenation?
Increases the oxygenation.
Improves
Ah.
oxygenation.
So in air days, all of you forgot about COVID time, isn't it? I think all of you joined after COVID. Your PG. Is it?
Yes, sir.
So you have not seen
Yes,
the severity of hypoxemia. Okay. So improves gas exchange compliance. It is a quite cheap method, quick and easy, reduces requirements of adjuvants like inhaled nitric oxide or prostacyclin or even more. What are the disadvantages?
Because
Hemodynamic
sudden
stability
hypotension.
decreased.
Barotrauma mainly require high sedation and paralysis, hemodynamic instability, barotrauma, hypercapnia, decrease in oxygenation due to shunting of blood to poorly ventilated alveoli and ventilator-induced lung injury. All these things are disadvantages. How is the staircase maneuver done practically in the ventilator? Or how do you do the recruitment maneuver? What are all the steps? Supposing you find there is a collapse or atelectasis in the X-ray, and your assistant asks you to do the recruitment maneuver in the ventilator. What are all the adjustments you have to make in the ventilator?
First, we should sedate and increases the oxygen flow
And increase PEEP.
from 20 millimeters of mercury for 20 seconds, then 30 for 30 seconds, then 40 millimeters of mercury for 40 seconds.
And we have to watch the peak airway pressure, sir, during this process.
So it is mainly manipulating the peak, positive and expiratory pressure. Okay, so pressure control ventilation, 15 plus or minus 3, start peak at 10 centimeters of water, then step up peak to 20, 30, 40 for 2 minutes, then step down by 2.5 centimeters for 3 minutes. Okay, that is the practical method of doing this. Now some questions on mechanical ventilation to find out or assess your knowledge on the parameters of mechanical ventilation. You have to just say true or false. The dynamic compliance is the tidal volume divided by the difference between PIP and plateau pressure. True or false?
Peak. True. True, sir. True, sir.
True.
True, sir.
Correct. True. Yes, I agree. So very easy. You have to make a choice. Toss பண்ணி கூட போட்டுறது. Head or tail மாதிரி சொல்லுது. A deceleration flow pattern is seen with volume control ventilation. True or false?
True, sir.
You see the graphics in the ventilator. Deceleration means it goes to the peak and then start declining like that. That's called the deceleration flow. Do
True.
you have it in volume control?
Yes, sir.
Yes, sir.
Pressure control.
Volume control until the tidal volume is delivered, somehow it will maintain that. It will not come down. Only pressure will start coming down to prevent barotrauma. Okay. So your deceleration flow pattern you will see only in pressure control ventilation. Plateau pressure is the measured pressure at the end of expiratory phase of the ventilatory cycle.
True, sir.
How many of you are joining says true?
No, sir. False, sir. It's
False, sir.
very fast,
It is
sir.
false.
It's
It
very
is at the end of inspiratory phase. Okay. So plateau pressure, when they see when the ventilator graphic, if you remember, I am not able to put the picture because of lack of space here. So if you peak like that, remain plateau like that, then suddenly expiration will start, isn't it? So that is how the graphics will appear, the waveform. So it is at the end of inspiration. The plateau pressure is measured at the end of inspiration before the start of expiration, not the expiratory phase. A Reynolds number less than 2000 predicts a chance for turbulent flow.
False.
False, sir.
False.
False.
2000.
Very good. It's more than 2000.
4000.
Then only it will become turbulent flow. Airway resistance on ventilatory system may be monitored using pressure volume loop display.
True.
Look, I guess
Sir.
True. True.
two is right. Yeah, you can see, it will cause what is called bowing of the BOWIND. Just like a bow getting bent, it will increase the volume loop. And dynamic compliance will always be lower than static compliance.
It's true, sir.
Yes, true, correct. Trans airway pressure is the sum of alveolar and airway pressure.
Not some, sir. Minus.
False. False.
It is
False.
a gradient. Very good. So it is a false answer. Volume control ventilation can compensate for leaks in the circuit.
False, sir.
No. False.
False. Very good. It cannot
False.
compensate. It will lose the volume. A high spontaneous respiratory effort with SIMV may lead to respiratory muscle fatigue.
Yes, sir. True, sir.
True. Very good. Pressure support ventilation is a pressure or flow triggered, flow limited, and time cycle.
Not flow limited, it is a pressure limited.
Is it true or false?
False.
False. Correct. Because it is patient triggered.
Patient.
Pressure support, you do it only during weaning. So it is patient triggered, not pressure triggered. And of course, it is not time cycled also. Whenever there is an attempt, it will support. Emphysematous patients have low static compliance.
It is high static
High.
compliance. sir.
False.
False,
So
sir.
it is again false.
False.
So high static compliance. Very good. Now, a 35 years old hockey player sustained fractured shaft of femur and has undergone intramedullary nailing and final anesthesia. On third post-op day, patient complained of sudden onset of breathlessness, oxygen saturation reduced to 82% in room air. Patient was disoriented, high flow nasal oxygen, sample taken, showed this is the pH, PCO2, bicarb, base excess, O2 saturation, sodium, potassium, and chloride. What is the interpretation of the ABB values?
Metabolic acidosis.
Metabolic
Alkalosis.
must always give a complete diagnosis. What is the bicarb like here? I mean, starting from the pH, it is alkalotic or acidotic?
Alkalotic.
Alkalosis.
PCO2 normal or low?
Sir.
Low, sir.
So, bicarb low or normal?
Low, sir.
Low. Base excess is low. Saturation is low. Sodium is okay. Potassium is okay. Chloride is okay. Okay. So, what is the basic pathology here? Is it metabolic problem or respiratory problem?
Respiratory problem also be.
Respiratory. In respiratory, why bicarb should go down?
Metabolic problem.
It is a primary metabolic problem because bicarb is low. It is being compensated by the respiratory system by washing out the carbon dioxide. So there is a temporary increase in the pH. In a completely full compensation, pH should have come back to less than
Normal.
7.45. Okay, 7.35 to 7.45. If the pH returns to normal with a PCO2 load, that you can call it as a compensated respiratory alkalosis because of basal metabolic acidosis. Okay? So here pH is 7.52, PCO2 is low, bicarb is low, which is acidosis. So change in bicarbonate is measured here. Whenever we need that, it should be 0.2 multiplied by the difference in the CO2 value, 2.6. Expected PCO2 should be only 21.4, whereas here it is 18. So it is primarily a metabolic acidosis due to hypoxemia compensated by your respiratory alkalosis. What could be the cause for the sudden change in patient's condition?
Embolism.
Fat embolism.
Fat embolism, because it's a long bone fracture which has been fixed, which is a very common thing. So fat embolism syndrome. How to make a diagnosis? What are the other things to confirm it is a fat embolism?
CNS manifestation, petechiae, and respiratory manifestation.
That's criteria.
The three things, which is called
Gert's
Gert's
criteria.
criteria. The neurological, patient is disoriented. Respiratory, patient is tachypneic. And cutaneous manifestations like petechial hemorrhages. If you look for that, it may be present. And fat globules in the urine also can be diagnostic. How is this condition treated?
Mechanical ventilation. Sir.
It's a supportive treatment. Mainly supportive treatment with ventilation, fluid resuscitation, including albumin.
Apnea test. Brain death.
Yes, sir.
It is testing for brainstem death. Okay, brainstem death testing. The first one is eliciting the pain response, pressing at the glabella. Okay. What is the second one? Examination of various
Yes.
cranial nerves. All these things are shown in the picture. Third one is apnea test.
Apnea test.
All the three are shown. How is brain death confirmed or defined?
Irregular cessation. Cessation of irregular.
Complete cessation of brainstem reflex.
Information of the irreversible loss of consciousness and irreversible apnea. That is the definition of brain death. Irreversible loss of consciousness and irreversible apnea. What factors exclude patients from doing this brain test testing? Who are all the patients where you cannot do the brain?
Facial bone fractures, any like alcohol consumptions.
On prolonged sedations.
Patients who are
Drugs.
paralyzed, who are sedation, they should not be hypothermic, first and foremost thing. Okay? And no metabolic or endocrine disturbance should be there. No depressant drugs or neuromuscular blocking agents should have been used, and cannot perform on patients with paralysis as in Guillain-Barré syndrome. What is legal time of death?
After the second apnea test.
After the second. Second is a confirmatory. Legal time is after the first.
First
The
test.
time where the first set of tests are completed.
Yes, sir.
What additional tests are done? Why are they done? Supposing this brainstem death is not very confirmatory.
Cerebral vein.
Cerebral angiography.
Angiography.
Four-vessel angiography,
Cerebral scintigraphy.
CT angio or transcranial Doppler, EEG, and auditory evok potentials. These are all the other tests that are done. They are done in cases of lung disease preventing apnea test or cases of craniofacial injury where cranial nerve testing is not possible. These are all the indications for the other testing.
Hypoxic pulmonary
HPV.
vasoconstriction.
Hypoxic pulmonary
Pulmonary vasoconstriction.
Very good. How is it acting? How does it take place?
Active mechanism where non-ventilated
When there is a hypoxia, there will be a constriction of pulmonary arteries.
Hypoxia where? In the blood or in
Alveolus, sir, non-ventilated
alveoli?
alveoli.
That is a very important point. To say alveolar hypoxemia or oxygen. So it's a property, protective physiological mechanism that diverts blood away from hypoxic or collapsed alveoli to better ventilated zone. It is the alveolar oxygen tension which triggers this reflex, causes this reflex vasoconstriction of arterioles around them, and this possible by reduction in the level of nitric oxide and the inhibition of oxygen sensitive potassium channels, which cause depolarization, which increases calcium and smooth muscle contraction. That is how the vessels go into constriction. This is a biphasic response, and the initial period of increase in the pulmonary vascular resistance, followed by a second more sustained phase of vasoconstriction. This is unusual response compared to systemic circulation, where hypoxemia results in vasodilatation to deliver more oxygen to the tissues. What is the significance of hypoxic pulmonary vasoconstriction?
During one lung
One lung
ventilation.
ventilation.
Early LVH, normally it's also useful. In early LVH, HPV is responsible for diversion of blood from the basal to the upper zones. In chronic lung disease, HPV will cause pulmonary hypertension leading to pulmonary and right ventricular failure. Cardiac shunts, hypoxia leads to increase in PVR, aggravating right to left shunt. Fetal pulmonary circulation, alveolar O2 is responsible for the hypoxic pulmonary vasoconstriction, which prevents blood flow into the lung because the alveolar O2 is low. And at high altitudes, HPV causes significant increase in pulmonary vascular resistance. So these are the physiologically important things or physiological pathology that is happening. But as an anesthetist, this is causing factors inhibiting HPV, like high FiO2, volatile anesthetic agents, including nitrous oxide, and it's important in one lung anesthesia, where we have to tackle this to prevent hypoxia happening.
Cardiac.
Float,
Cardiac.
float,
Cardiac output monitor.
cardiac output monitoring.
Minimally invasive cardiac output.
So many parameters, not only cardiac output.
Cardiac output, cardiac index, stroke volume radiation.
So this is a highly advanced Cecilio Edward Science Life Monitor. This is first of all the name they are given. Okay, and what does it monitor? It monitors so many parameters, not only cardiac output, it monitors cardiac output, pulse wave, arterial line, and how fluid responsiveness is identified using this monitor.
Stroke volume variation.
You can use this stroke volume variation. Stroke volume max minus stroke volume minus divided by stroke volume mean. So you can use that to find out the fluid. What are the advantages and disadvantages of this monitor?
Is a minimally
Advantages is a
invasive.
minimally invasive technique.
Hmm?
It is minimally
Fluid.
invasive technique.
Minimally invasive. Requires no manual calibration for cardiac output calculation. Like your earlier, how was the cardiac output calculated in the earlier days?
During the pulmonary artery catheterization.
Catheter.
With a pulmonary artery flotation catheter. We used to inject saline and then measure the temperature, and then the difference used to be calculated. So much of manual thing has to be done. Here there is no need for any manual calibration. Users enter the patient specific data, age, gender type. It is more non-invasiveness, works through an already existing arterial line catheter, and continuous monitoring displays then No central vein line is required, like your PA catheter. Okay. So these are the advantages. Disadvantages,
It's a high cost and
cost, very good. Good arterial signal quality is critical for accurate cardiac output. Elevation levels of PEEP can erroneously increase the stroke volume variation and warrant for fluid resuscitation. Then large changes in vascular tone or vasodilation may also uh, not give an accurate reading and does not account for differences in the pulse pressure readings recorded from different arterial cannulation sites. So it is the standard from the radial artery. When is it not reliable? Is this monitor not reliable?
Significant arrhythmia, sir.
During arrhythmias, hemodynamically unstable patient, and there is an intra-aortic balloon pump in use or ventricular assist device is in use. So these are all the situations where this is not the ideal. What is the range of normal values for all these parameters? What should be the cardiac output? What should be the cardiac index, stroke volume? So these are all the cardiac output can be anywhere between 5 to 6 liters. Okay? And cardiac index is 1.8 to 3.4. Stroke volume, like that you have the range for all these things. Cardiac output 4 to 6 to 8 liters. Cardiac index 2.5 to 4 liters per minute per meter square. Stroke volume 60 to 100 ml per beat. And stroke volume dynamic vascular resistance 800 to 1200 times per 10 per centimeter. And stroke volume variation is less than 13%. It is small letter. What is
Blood-brain barrier.
Blood-brain barrier. Very good. So this is the blood-brain barrier. What is the blood-brain barrier? How do you define a blood-brain barrier? Hmm?
Semi-permeable
So
membrane.
it's a physiological barrier, not an anatomical barrier. It's a physiological barrier between the blood and the brain tissue, which restricts transfer of molecules from plasma to brain. So what constitutes blood-brain barrier? What are the anatomical structures which constitute the blood-brain barrier? You can see in this picture.
Tight junction.
Blood vessel, endothelium.
Blood vessel endothelium,
tight gap junctions. Astrocytes.
basement membrane. So endothelium, basement membrane, astrocytes.
Astrocytes.
All the three form the blood-brain barrier. What are the functions of the blood-brain barrier? Why it is there? What will happen if it is not there?
Protective function.
All toxins can enter, all protection for brain, endogenous and exogenous toxins. Provide tight control of ionic concentrations like hydrogen, sodium, potassium, calcium, magnesium, to which brain is very sensitive. Protect brain from transient changes in plasma glucose levels also. It prevents release of central neurotransmitters into systemic circulation. Which pathological conditions affect the integrity of blood-brain barrier?
Parkinson's.
Huh?
Trauma.
Very good.
Epilepsy.
Inflammation, epilepsy,
Tumor.
meningitis, acute and chronic hypertension, epileptic seizure, multiple sclerosis, Alzheimer's, and of course trauma also. Which parts of the brain lie outside the blood-brain barrier and why is it so? The area postrema, median eminence, pineal gland, neurohypophysis of posterior pituitary, and choroid plexus. All these five structures are outside the blood-brain barrier. Area postrema is also known as vomiting center, protects from toxins entering the blood. So as soon as the blood has the toxin, this area postrema will be exposed to the toxin. So immediately, especially from the gastrointestinal tract, and it will induce vomiting and makes you eliminate that vomiting from the toxin from your body. And the second to fourth, median eminence, pineal gland, and neurohypophysis, they regulate their anterior and posterior pituitary hormone secretions into the blood. And pineal gland secretes also melanin, important for circadian rhythm. Okay? So these are the important. What is the instrument shown here and what parameters are displayed?
Pulse oximetry,
Pulse oximeter.
saturation, heart rate, and
Finger
perfusion
probe
index.
pulse oximeter. The finger probe display. Okay. So what are all the things that have been displayed? You can see so many lines. 1, 2, 3, 4, 5, 6, 7 lines are there. So what are the things that are being displayed here?
Heart rate, saturation, perfusion index.
Hmm. You have heart rate, you have saturation, you have perfusion. Like what is this?
Battery.
Battery charge. What about this? And what is this? What is this? So
Serial
SpO2,
waveform.
SpO2 is being there, pulse rate is there, plethysmography tracing is there. This is called the pulse rate bar. Every time, when the pulse is there, it will go up and down. And what is the perfusion index and its importance? Here it is written
Pulsatile to
PPG.
non-pulsatile blood
Ah.
flow.
is the ratio of pulsatile to non-pulsatile flow and indicates the adequacy of tissue perfusion. Okay, so that is the important. What is the normal value?
Less than 1, sir.
Up to 8%. It will be anywhere between 2 to 8%. Why the light emitting diodes, if you have seen, switch off and on again with a pass? You open it and see the red light inside the probe, it will not be continuously glowing. It will be switching on and off. What is the reason? This will eliminate the photodetector, allows the photodetector to process and pick up ambient light signal and compensate for the pulsation done. So earlier they used to have a cover for this pulse oximeter so that the ambient light does not fall on it. Later now there is a new technology which will eliminate all this interference. What is the technology called? All the artifacts can be removed. And the real saturation can be calculated and displayed. What is that? Like movement, like external lighting, the temperature, all the artifacts can be eliminated. And the correct saturation can be displayed. It's called Massimo technology. How does pulse oximeter measure arterial oxygen saturation? What is the principle behind that?
Lambert's law, sir. Beer Lambert's law, sir.
Here Lambert law, correct. But what does it say?
The toxic hemoglobin reflects the infrared light at 640 nanometer.
Oxy and deoxyhemoglobin
Hemoglobin.
absorb infrared light at different wavelengths.
Wavelength.
Okay, it analyzes pulsatile component, ignores non-pulsatile part to eliminate absorption by venous blood and tissues. And what is isobestic point?
Two or more wavelength will be that absorption will be equal.
Iso means same.
Same.
Okay, it is a point at which two substances absorb certain wavelength of light to the same extent. For example, oxy and deoxyhemoglobin, it is at 590 nanometer red spectrum and 805 in infrared spectrum. It can be used as a reference point where absorption of light is independent of the saturation. That is the reason why it was used here. What are the limitations of pulse oximeter?
Battery operated, sir.
Battery operated. Where it cannot be.
It is not
reliably-
required.
Nail polish.
Less than 92%.
Nail
color.
polish, any
Inaccurate,
Artifacts,
low
colors.
50% of saturation,
Chalk.
low vasoconstriction because low pulsatile health, atrial fibrillation and other arrhythmias, excess movement and ambient light, nail varnish, especially green and blue colors, cardiac carbon monoxide poisoning, methemoglobinemia, methylene blue and dyes. In all these situations, it will not give the correct. Okay? So many things are there. Now coming to the body water content. How is total body water controlled? Basic physiology.
Osmolarity, sir, best.
Osmolality. Then, if you say one letter,
Hormone. Hormonal influence.
the integration of three components. One is sensors, osmoreceptors, volume receptors, and high pressure baroreceptors. They all sense change in fluid osmolality and total body fluid. One. And these messages are received by hypothalamus, which is the integrator for all the three to increase or decrease water intake. So when there is a low water content, it stimulates thirst to increase water intake. And there is a high water content, it stimulates, also it stimulates the ADH to retain water. But if you have excess water, ADH release will be stopped so that you will have more diuresis because it is an anti-diuretic hormone. Okay? So these are the three important things. There's a sensor which sends message to hypothalamus, and hypothalamus acts by increasing your thirst or adjusting your ADH level. This is how the entire body water is controlled. Which cell membranes in the renal system are impermeable to water? That water cannot enter through those membranes or the cells.
Ascending loop.
Huh?
Ascending loop of
Ascending loop. Then only one thing. Two sides in kidney and one side outside the kidney. That is a clue I can give you. Or two parts of the nephron and one outside the kidney.
vasa
So
recta.
outside the kidney, can you take a guess?
Vasa recta, sir.
Outside the kidney
Kidney.
is extrarenal. Where does the urine ultimately drain from the kidney? Through the ureters.
Yes, sir.
Where does the urine formed in the kidney go to? Through the ureters. What a very difficult question as a
Calyxes, sir.
Collecting the film.
bladder epithelium. Urinary bladder epithelium does not permit water. Otherwise, urine it will get reabsorbed. Ascending loop of Henle and cortical and medullary collecting ducts. These are the three locations from where water is impermeable. Okay. What is the definition of a crystalloid and colloid? How do you define crystalloid? How do you define colloid?
Crystalloids are small molecules.
Do they go out of the membrane or the compartment
Yes, sir.
easily? Or?
Yes, sir.
So crystalloids are solutions with small molecules which dissociate into ions which can pass through semivalvular membranes easily. Okay.
Yes, sir.
What about colloids? So
Colloids
opposite
are large
side,
molecules.
large
Does not cross through
molecules
the membrane.
dispersed in the solvent which do not pass through the semipermeable easily. Okay, that is the difference. So how much of fluid will be retained in a vascular compartment if you infuse 1 liter of sodium chloride or 1 liter of 5% dextrose? That is 1000 ml of sodium chloride if it is infused into the vascular compartment, or 1000 ml of dextrose if it is infused into the vascular compartment. How much will be retained inside the vascular compartment? All of you know there is a vascular compartment, there is an interstitial compartment and intracellular compartment.
Yes, sir.
So whatever fluid is injected into the vascular compartment, it will get dispersed to the interstitial space and then it will go into the intracellular space depending upon the gradient. Isn't it?
Yes, sir.
So how much will be retained if you infuse 1 liter of saline? How much will be retained if you infuse 1 liter of 5%? In ml, you can calculate and tell in ml. So the method of calculating is sodium chloride is
20%.
isotonic, so it will distribute among extracellular compartment and intravascular volume will be 25% of the extracellular compartment. This is the total volume. So 250 ml will be retained. You give 1000 ml, you can expect 250 ml to be retained in the vascular compartment because 25% is the volume. Whereas when you give 1000 ml of dextrose, dextrose will be metabolized immediately and it will leave only 1000 ml of water, which is hypotonic. So water will distribute equally in total body water. That is 2/3 into intracellular and 1/3 into extracellular. So 333 ml will be going out into the extracellular compartment, which is about, of which 1/4 is the intravascular compartment. So 334 divided by 4, you have only 84 ml left in the intravascular compartment. So this is how the calculation is made. So how is fluid moved from compartment to compartment? It is from intravascular to interstitial and intracellular, or intracellular to interstitial and intravascular. What is the mechanism of movement of fluid? Or what are the factors governing that? Second year physiology is nothing more than that. first year physiology now. Nowadays you study physics, physiology, and anatomy first year itself, isn't it?
The hydrostatic and
Fluid is
Hydrostatic
moved by a combination of osmotic and hydrostatic pressure. Osmotic pressure results from difference in the solute concentration across cell membrane. Hydrostatic pressure results from the pressure of blood as it enters the capillary system, forcing some fluid out of the vessel into the surrounding tissues. Okay? These are the two pressures which are responsible for the movement. A 47-year-old man who is in respiratory distress and hypotensive, his X-ray test brought to the emergency. What is the condition? How is it treated? Are you able to see the X-ray well?
Yes, sir.
Consolidation, sir.
Ah, very good. Consolidation where?
Left, right
Right,
side.
right side.
Right
Lower
basal
lobe.
region. Okay, right lower lobe or right. X-ray shows right lower lobe consolidation. So this is a medical emergency since patient is in respiratory distress and hypotensive. So first thing you have to do is a ABC survey, airway breathing circulation. We at least start high flow oxygen via non-rebuilding mask. Then call for help, secure 2 large IV access, 2 sets of blood samples, commence fluid resuscitation. Because once you make a consolidation or pneumonia, it's a septic focus. So it's not contraindicated, start broad spectrum antibiotic also. Assuming this is a case of septic shock, what are the 2 bundles described for that?
Registration
One
bundle,
hour.
but one
Ah,
registration bundle and maintenance bundle.
maintenance bundle. Oh, very good. So first thing is resuscitation bundle at 6 hours. And the factors that we have to take into consideration is measurement of lactate, taking blood culture before antibiotic, administration of broad spectrum antibiotic, fluids at the rate of 20 to 40 ml per kg, vasopressors if needed, adequate central pressure, adequate central oxygen saturation. These are all the initial things we have to do it. Then second is the management bundle in 24 hours, and that is composed of low dose steroids, activated protein C, adequate glycemic control, prevention of excessive plateau pressure upon mechanical injuries. What is goal directed fluid therapy? Earlier, this 20 to 40 ml was called as liberal fluid therapy. But nowadays, most of the time we aim for what is called goal directed fluid therapy. What are the aims of this goal directed fluid therapy?
Using monitors like stroke volume variation and pulse pressure variation, we give a restricted.
Pardon?
Using a stroke volume variation, pulse pressure variation, we give a restricted fluid therapy, sir, not liberal fluid.
Now, why we are nowadays talking about goal directed fluid? What do you want to achieve by this goal directed fluid therapy?
Avoid excessive
Fluid
Ah.
accumulation.
avoid fluid overload and
What is the ultimate aim of any therapy or oxygen therapy or fluid therapy? Ultimately, what do you want to achieve?
Resuscitation.
Hemodynamic stability.
Hemodynamic parameters.
Deliver oxygen to the mitochondria because the cell has to do oxidative phosphorylation. That is the basic thing that we have to aim. Okay, so that is what we want to achieve. It's a strategy that aims to optimize tissue perfusion and oxygen delivery. This is the most important aim to any therapy, whether it is goal directed or hemodynamic. We want to optimize tissue perfusion and oxygen delivery by carefully monitoring and adjusting fluid administration based on dynamic hemodynamic parameters, not the static. Okay, earlier it was all static parameters we were calculating. Now we are using dynamic hemodynamic parameters like stroke volume variation, pressure index, and all those things. Okay, so the aim is for optimized tissue perfusion and oxygen delivery.
Cardiopulmonary bypass.
Cardiopulmonary bypass.
Cardiopulmonary bypass or heart lung. Very good. What are the basic components?
Roller pumps, oxygenator,
Hmm.
and venous and arterial cannulae,
Pumps.
heat exchanger.
Some care heat exchanger is also very important. Tubing made of silicone or rubber pump to propel blood, two types, either roller or centrifugal. And oxygenator, which is a membrane type, mostly used, bubble type not frequently used. Heat exchanger, cannula to drain and breathing tubes. What is priming? How and why it is done?
To avoid air bubbles in the circuit and So, circuit
remove
with
the
air.
air, de-airing. Okay, remove the air from the entire circuit and the machine. It's called priming. Priming is done mainly to remove all the air from the tubing and CPB machine to prevent air embolism. Priming can be done using crystalloid for adults or blood for pediatric patients. How is the blood prevented from clotting and how is it assessed? The
Using
adequacy of
heparins.
the
Using
heparin
heparins,
is
sir.
very good. How is it assessed? That
Active
is
times, sir.
activated clotting. Heparin at dose of 300 international units per kg given intravenously before commencing bypass. Adequacy is tested by activated clotting time. It should be 4 times above normal. What is the normal time?
120 seconds, sir.
180 seconds. Isn't it? So 4 times is 750 times. Okay, that is how it is calculated. What is shown here?
pain
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 pathway.
pathway.
Pain pathway. Very good. Pain pathway is shown here. What is pain modulation? How is it done? You say you modulate the pain. How do you
Head control theory.
Hmm. First of all, what is the definition or explanation for pain modulation? Is it decreasing or increasing the pain?
Decreasing the pain, sir.
You try to decrease. So, what are the methods of decreasing the pain? Is there any
Central
natural
sensitization
mechanism
and peripheral
artificial?
sensitization, sir.
Pardon?
Central sensitization and peripheral sensitization, sir.
Pain modulation is body's natural ability to regulate and alter the perception of pain. That is the definition of pain modulation. Refers the body's natural ability to regulate and alter the perception of pain. And gate control theory, descending pain modulation, conditioned pain modulation, and endogenous opioids help in this modulation of pain. The four things are there. What is the significance of pain modulation? Why we have to know about this? Do all patients feel pain in the same way?
No, sir.
When you operate, do all your patients say uniformly the same type of pain, or some people are better tolerant, some people are very, very least tolerant? Does it vary significantly from patient to patient?
Yes, sir.
Yes. The pain modulation explains why individuals respond to the same stimulus differently. Mechanism of action when using clinical analgesia is useful so that some patients may require a very heavy dose of painkillers. Some patients may not require that much. Okay, all that is because their natural ability to regulate and reduce the pain is very good in some patients. They are lucky. Okay, so what is opioid-induced hyperalgesia and how do you treat this? What is the normal action of opioid? Do they reduce pain or increase pain?
Use the pain.
Reduce
They
pain.
are supposed to reduce pain, but when they themselves can increase their perception of pain, causing what is called hyperalgesia. This is a paradoxical situation, isn't it?
Yes, sir.
So how to treat that condition? So it is a
Avoid-
paradoxically increased perception of pain in patients on treatment with opioids. That is called opioid-induced hyperalgesia. How can you treat it?
Avoiding opiates and using other modalities like
Go for other more. Treat with NSAIDs, gabapentin, acetaminophen, antidepressants, or rotation of opioid drugs. These are all the methods of managing opioid-induced cycle. What are the different methods of treating pain at various levels, right from the site of injury and as it gets transmitted from the periphery to. So, from this picture, how does the pain pathway conduct the pain? This is the, supposing this is the site of injury. What are the fibers which conduct the pain?
A delta fiber and C fibers. A
A
delta for
delta.
cause
A
pain and
delta conducts what type of pain?
cause pain.
Fibers? What type of pain they will conduct?
A delta fiber is
Fast
fast pain
and
and C
sharp
fiber
pain.
is fast.
Short, slow pain.
Slow
The
pain.
dull pain is conducted by C fibers
C
and sharp
fibers.
and fast fibers are L delta. So they go to the posterior horn through the ganglion, then they end there. The first order neuron is there, the second order starts, then desiccates to the opposite side as the spinothalamic tract, goes to the brain stem, then goes to the thalamus, where the second order ends, and then the third order neuron goes to the cortex. Okay? So there are three relay stations: first order, second order, third order. So we can interrupt it here, 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 here. So all the four locations you can do that. So this is the stethoscope. So you can block it at the site of injury section where the painful stimulus is done. What is transduction? Definition of transduction.
The electrical signals at the pain nerve ending is called transduction.
Electrical
The production of electrical
conversion
signals
of
from
chemical impulse into electrical impulse is called transduction. See, when you get an injury, immediately lot of cytokines, the chemicals are all released, inflammatory cytokines are released, isn't it?
yes,
So
sir.
that cannot directly convert it to the nerve. So the conversion of the chemical energy into electrical energy is called transduction. And transmission is the conduction of this electrical energy through all the
Fibers.
fibers. And perception is at the thalamic and at the cortical level. Okay, so you can do interruption at all these levels. At the local level, you can apply local anesthetic, anti-infectives, opioids, do the intrathecal, all these things. And then at the transmission at the synaptic junction or descending pathway, you can use the same drugs here and they can give cognitive behavioral therapy pattern. So like that you can do interruption at various levels.
Peripheral nerve stimulate.
Question is, what block is being performed here?
Interscalene.
Left interscalene block.
Interscalene. You can see the person holding the interscalene groove and trying to. So interscalene approach to brachial plexus block using peripheral nerve stimulator and a catheter insertion, maybe for extended pain relief. What are the indications for this approach?
Shoulder surgery.
Shoulder and upper arm.
Shoulder surgery. Okay,
Clavicle
upper arm or elbow. What are the landmarks for this technique? If you are doing it as a landmark for technique, what are the landmarks? And what is the technique of doing this?
Winnish approach we are using, sir.
Posterior
Landmarks,
sternocleidoid
tell
and
the name
clavicular
of the
head of clav.
muscle, the location,
Sure.
the level, everything. Winnish
Sure.
approach na oru thara pota examiner will. Do you expect the examiner to understand what is Winnish approach?
No, sir. I'm telling, sir.
You are telling what?
The approach, sir. Sternocleidomastoid
See,
muscle.
writing the name of the approach is not enough, ma. You must tell all the landmarks.
Yes, sir.
How do you make the
Yes.
landmarks? How do you do that? The position
Yes,
of
sir.
the patient is supine. Head turns slightly to opposite. Preparation all around the site of puncture. Palpation, lateral border of sternocleidomastoid. Identify the external jugular vein. Palpate the interscalene groove. And puncture, insert the insulated needle in a BID direction, backward, inward, downward, at the point where EJV crosses the lateral border of sternocleidomastoid. This is how you have to write. And the effect of stimulation is twitching of deltoid or forearm muscles at a current of 10.5 milliamperes, indicative of proximity to the nerve. What are the complications that this approach can produce?
Phrenic nerve injury, sir.
Hmm.
And
Phrenic nerve injury or blockade?
phrenic nerve blockage.
More commonly block, generally very rarely injury.
Yes, sir.
More serious complications than phrenic nerve block.
Arterial.
Can you go into the vertebral canal and produce the subarachnoid block if you are not sure about the depth? Lot of final injection, epidural injection, vertebral artery puncture, very rarely pneumothorax. Nerve injury like one of the roots or trunks of the plexus can be injured, and phrenic nerve also can be blocked. What is the risk of performing bilateral interscalene block?
Diaphragmatic pulse.
Bilateral phrenic nerve block. Okay, so that can lead to severe respiratory distress. Should never do that.
Indirect laryngoscopy.
Indirect
Indirect
laryngoscopy.
laryngoscopy. Very good. View of larynx by indirect laryngoscopy. What is the other method of viewing the larynx? And how is it classified? You said there is an indirect
Direct
laryngoscopy.
laryngoscopy.
Direct laryngoscopy could be the other method. Other method is that. How can you classify direct laryngoscopy?
Video assisted.
Pharmacogenic grading.
Pharmacological grading is visualization or the various visualization of structures in larynx. But this laryngoscopy itself, based on the instrument that you use, can it be classified? Or equipment that you use to visualize the larynx? Can be rigid or flexible scopes. Okay? Classified based on the instrument you use, mainly rigid direct laryngoscope like your Macintosh, Miller blade, all that is all rigid blade laryngoscope. If you use a fiber optic or a video assisted laryngoscope, it's a flexible scope. What is a video laryngoscope?
It has a portable, it's a camera at the tip of the scope.
Camera is attached to the blade. Okay, then what other components are there in the video laryngoscope? The blade with the camera, the light source connected to a monitor. Okay, that is called the video laryngoscope. What are the types of video laryngoscope? Give names of each models or some of the models used.
Channel,
Rigid blade type.
Channel, non-channel.
Channeled and non-channel. Very good. Real scopes can be channeled or not channeled. Channeled are example C-track and A-track. Non-channel can be a standard blade video scope, C-mat or V-mat, or it can be an angled blade, light scope and mega. What are the advantages of video learning?
Easy visualization of the
time and
blocks.
it is used for difficult airway.
First and foremost,
Prints,
time.
advantage.
cervical spine.
You need not position the head and neck as you want to do it for the rigid blade. Your conventional Macintosh laryngoscope, you need to position the head, flexion at the cervical spine, extension at the atlanto-occipital joint. It's not required. You can keep the head and neck in any position. Okay, improved laryngeal vision, less force required, less cervical spine movement, less hemodynamic response, short learning period, improved portability and cost, useful teaching tool, high success rate, especially in difficult cases. These are all the advantages. What are the disadvantages?
Difficult to pass the ET tube.
Difficult.
Difficult to pass the ET tube inside the vocal cord.
That's the only disadvantage. You say at least 3 or 4. There are so many. Fogging and secretion may obscure the view. Passage of the tube may need a staylet. Loss of depth perception. Economic issues over stock acquisition and maintenance. Greater processing time. Different makes and models need different approaches. These are all the that's top ask you for the day. Being a weekend with a long weekend for all of you. We planning to go home.
No,
During
sir.
holiday.
No, sir.
We're not having leave, sir.
Not allowed. So anyway, happy Independence Day. Happy Gopalaష్టami to all those celebrating.
Thank you, sir. Wish you the
Thank you, sir. Happy Independence Day.